Um, so we have two of our great surgeons here who are going to lead us on this. We're going to start with Dr. Bethany Hedt here, who will address us first. We'll go with Dr. George Dyer. And then feel free to send me any messages. You can send them to me directly in the chat feature. And we're going to do a Q&A at the end. And so we'll ask some of those questions that you guys have been wanting to know as well. So Dr. Hedt, we'll start with you if that's okay.
Great. Can you see my slides?
Yes, we can.
Great.
Yeah.
I just put together a few slides to organize some thoughts for relevant to the conversation. So my name is Bethany Hedt-Gautheir. I'm faculty at Harvard Medical School. So I'm going to talk a little bit about myself and the work that I support in the field of global surgery. And then I will end with a few thoughts relevant to the seminar about how students and fellows can be more engaged in global surgery research. So a little bit about myself. So Taylor, actually, I'm not a surgeon. I am actually a mathematician and a statistician, and that is the role that I play within our surgical projects. I consider myself an equity advocate. I try for the work that I do to really address issues that focus on health equity, no matter where they are. I consider myself an Afrophile. You'll find that almost all of my work at this point is in sub-Saharan Africa. Long story short, had some early exposures and traveled a lot in the area and have now spent about half of my adult life in different sub-Saharan African countries. In a lot of ways, I consider myself as much at home or not at home in different parts of Africa as I do in Boston, and definitely enjoy having my time there. I'm a health systems researcher, so I focus not just on any single activity, but how activities string together to promote health. And then a large part of my work is teaching, training, and as a mentor to different projects. Most recently, about 5 years ago, I was exposed to the field of global surgery and decided to focus on the field of global surgery. And most of my work that I'll talk about is in the area of surgical care and outcomes in rural district hospitals in Rwanda. So why global surgery? When I was exposed to the field and trying to decide what my topical focus was going to be for my career, recognized that it is a cornerstone of health systems. In a lot of ways, I thought surgery was a way that I could cheat because I've been able to look at maternal health from the field of surgery. I've been able to look at oncology from the field of surgery. I've been able to look at water sanitation and hygiene from the field of surgery. And so focusing on global surgery gives me a lot of flexibility in terms of what I study. There was, at the time, 5 years ago, importance in gaining importance in global recognition of the field of global surgery. There was very little primary data, what was happening in surgical practice was oftentimes not following global protocols. So I felt like it was a real opportunity to use research to improve surgical practice in various countries. The other reason why global surgery is there's very few non-surgeons working in the field. And so it felt like a space. My previous life, I was an HIV researcher primarily, and it felt like there were very few non-surgeons working in global surgery, and that there was a space that I could occupy that would be unique and helpful. And then I really liked the people who worked in the space. I collaborated with Robert Riviello for many years in Rwanda through the Human Resources for Health program, and just really appreciated his approach and philosophy. And so basically chose the field of global surgery because I just wanted to work with him more on future research. So just an overview about surgery in Rwanda. There were very few specialists, and all of those specialists were based in central locations until 2016. The Human Resources for Health program, in which I was a statistician, was primarily focused on growing clinical workforce and has increased the surgeon, obstetric, and anesthesiologist density, and is continuing to increase and have an impact there. But there was a lot of questions around the health systems aspects of the work. And so even though there's more people working in the surgical space in Rwanda, there's still a lot of questions about the health systems. And then you'll find that most of my work is on C-section, primarily because the hospitals that I do research at all the care that they're providing. My work in global surgery started as operational research. So operational research is research that can be done primarily using existing data. So you might have to spend some energy harvesting that data from patient charts or from registers. but it's existing data and it helps you understand care and outcomes within the existing health system. And so this is just a highlight of some of the first papers that I supported in global surgery from Rwanda district hospitals, looking at patients who had surgically resectable cancers, looking at the ability to provide non-obstetric care, looking at referral patterns and delays for patients going from district hospitals to central hospitals. So these were all papers that we started using existing data. And from that, we've grown into 2 grants that have been supported by the National Institutes of Health. The first one, what we were trying to do is optimize returning patients after discharge from the hospital when they might develop a surgical site infection. And what we were hoping to do is to find a simple protocol that could be used by community health workers to identify patients in their home and then link them to care if they had a suspected surgical site infection. And so through that study, we prospectively studied 1,500 patients over 2 phases. The first phase, developing that protocol, and then the second phase, a randomized trial, looking at different modalities of delivering that tool. I'm going to just for time skip the primary results. Really for us, the more interesting findings were in the secondary analyses. So one of the things that we found was that 11% of women go on to develop surgical site infections after C-sections. That antibiotics are overprescribed. They're prescribed very much off protocol, and women receive 3 antibiotics as prophylactic care as part of their C-section in rural district hospitals. That water, sanitation, and hygiene conditions are poor and variable at both the hospital and home, and that we found a significant link between days without running water at the hospital and the development of surgical site infection. I don't know if those noises can be muted. Sorry, there's just a lot of microphone coming through. C-sections can be financially catastrophic for families, and we're finding this both in the care that they receive up to the time of discharge, but then also post-discharge. And then long distances from home to hospital are linked with negative health outcomes across a variety of spectrums, both for neonatal outcomes after C-section, but then also increased risk. It was around 20% of women were experiencing financial catastrophe as a process of the C-section itself. But that was just looking up to the time of discharge. And so we've been working with a surgical, he was then a medical student and is now, is in a PhD program. He's finished med school and is in a PhD program. But he's helping us model the costs, and we find that the number of women who experience catastrophic expenditures doubles when you take into account the cost that she has to pay for follow-up at health centers, and that additional catastrophic expenditure could be reduced if we were able to safely follow women in their home. So a large part of my work right now is trying to develop comprehensive programs for community health workers to visit women in their home, identify some of the most prominent complications post C-section, and then if any of those are identified, then to refer the woman back to care, instead of just requiring that she goes back to care multiple times in the first 10 days after discharge. So we currently have a study underway funded by the NIH that's looking at telemedicine. This is more traditional telemedicine, where a photo would be taken and sent to a general practitioner remotely, who would look at the photo and diagnose whether or not he or she suspected a surgical site infection. But we're also looking at a second study where we've been training the machine learning algorithm to do this automatically on the phone. And the benefit of this is that it doesn't require for this to be transmitted over cell network. So we don't have to rely on the network at all. We used our preliminary data from the first study and actually found an algorithm that was 99% specific and 100% sensitive. So we think that this is a very viable option. We're field testing the algorithm now, and we're applying for a grant to look at its generalizability to other populations in sub-Saharan Africa, and then also in other parts of the world. So future lines of inquiry for our work is looking at what should comprehensive post C-section care look like. it's not actually clear. There's no global guidelines on what should happen once a woman leaves the hospital. And from my experience, those guidelines don't exist in for most surgical procedures in low and middle income countries. So we're trying to better understand that and then to see what community health workers can support. To look at whether or not image-based diagnostic algorithms are generalizable to other populations and how they can be integrated into health systems for better care. And then we're trying to better understand how to prevent and control surgical site infections, both looking at antimicrobial resistance to surgical site infections, and then interventions around water, sanitation, and hygiene to prevent infections. So the other place that I do a fair amount of work that is relevant for this conversation is looking at equity and research partnerships. So this is just one recent publication that we had that was looking at publications from sub-Saharan Africa, the percent of authors that were from the country that the research was about. So if you look at the first column, a little over 50% of all authors on manuscripts from sub-Saharan Africa on health included, 50% of all authors were from the country that the research was about. And it actually remains pretty consistent across first, middle, and senior authors. However, if you look at papers where one of the collaborators is from a top institution at a top US university, that drops overall. And then it drops considerably in the more prominent positions that individuals, the more prominent first and senior author positions. And I've actually just done a quick and dirty analysis of this, looking at surgery papers. And what you'll see is the shaded lines, the shaded bars are surgery publications. And so if you look just at the first set of lines, overall, surgery publications are less inclusive of authors from the country that the research is about. And that is overall, and if we just reduce to papers from top institutions. And you can see as you move across the first author positions and the senior author positions, surgery papers are even more egregious offenders in terms of inclusiveness of authors from the country that the research is about. And so we really try to focus on this head on with the work that we do in Rwanda. So you'll see the picture on the right is our study team that was taken about a year ago. The colleagues shaded in orange are our colleagues from Partners in Health. In blue are our colleagues from the Ministry of Health, and red are our colleagues from Harvard and from the program of Global Surgery and Social Change, and in green from University and Global Health Equity. We had a paper published early last year that talks about the initiatives that we take on to try and be equitable in the work that we do. And then, I highlight a few things on the left. So we support on-the-ground trainings with a focus on global surgery. So those operational research papers that I talked about at the beginning, we have a year-long training series and one that's just underway where 4 papers will be about surgical challenges or opportunities in district hospitals and led by Rwandan colleagues. We're supporting 2 of our collaborators to get PhDs, the first in general epidemiology and the second in data science. And then we host a variety of fellows and students in Rwanda. But again, if you look at the paper, we're very intentional about how we engage them in our research work. So just the last slide to think about how trainees can get involved in ethical global surgery research. So the first is identifying faculty that lead work that you admire and focus, look at things both the focus, the topics that they study, but also the process and how they engage teams, both other students, how they've supported them and mentored them, but then also the collaborators on the ground. Be realistic in what you can commit, and this is a whole host of things. Challenges that have come up for me in the past is students having unrealistic, not communicating realistically what their time availability will be, or their other commitments, and then also what their skills really are. So I think everyone in this group, I imagine, has very unique skills to bring to the table, but to recognize if you haven't had formal statistics training, that may not be the skill that you're bringing to the table, and to just be upfront about what you're bringing and what you hope to get out of the experience. I think it's important to calibrate your expectations. You definitely want to advocate for yourself, but you want to be sympathetic to the others on the team. So one of the challenges that consistently comes up for me across a variety of disciplines that I work in is that folks will clamor to be first author, but not really take a step back and think about who else has been working in that space for longer or in different ways and how they might need to be featured or supported in their professional path. Make sure that when you are advocating for yourself, that you're also advocating for others. I definitely have blind spots when I think about authorship lists and forget to include people. And so, having folks who work closely with colleagues support their advocacy efforts is helpful. And to make sure that you're making a plan with your mentor and your faculty that's very specific in terms of timeline and what you will get out of the process. Be ready to contribute, but not necessarily to the lead. I think that's particularly important. My understanding is this is largely targeted at students who are looking for training and exposure experiences, but may not have a ton of time to be able to take things on in a full leadership role. And I think in those positions, just to be ready to be an active learner and active contributor, always be ready to pay it back and pay it forward. So pretty much anyone I engage, student or fellow, they're going to be working on things that are closing up previous projects, oftentimes without getting any authorship or engagement out of it. And they're going to be helping write protocols and grants for future work that will engage students. And then they'll always have something that they're in the moment leading. And so, knowing that faculty, they're sustaining 10, 20, 30-year research portfolios, and you're stepping into a year for that, just being ready to look both backwards and forwards and how you support projects is helpful. And then just to generally acknowledge and appreciate those contributing around you, and make sure that you see the diversity of roles that individuals play and the expertise that people bring in, and make sure as you're representing the work more broadly that you're acknowledging their contributions to the project. So just a few acknowledgements, and I look forward to hearing more about your interests and questions as we open it up for conversation at the end. Thanks. And I think Taylor muted everybody.
Are you able to hear me?
Yeah, I can hear you.
Thank you so much. That was great. I apologize that my internet has been giving me issues. And thank you so much also for bringing an epidemiology point of view for us and sharing your expertise on that. It's great to have you here with us, and we really, really appreciate your remarks. Look forward to hearing more from you. We'll transition now to Dr. Dyer. Dr. Dyer, are you able to hear me? Let's see.
Hello, I'm speaking. Can you hear me?
Yeah, I can hear you now. Great.
Okay, good.
Can you hear me?
Yes.
I sent you an email. If you wouldn't mind, would you mind just sending your slides to Anusha as well? Because it seems that mine is not holding all the time and just don't want it to cut out.
Sure.
I sent you an email with her
Yeah.
and everything.
I'm sorry, I wasn't reading email. I was listening, so I wouldn't look at my email. Let me see.
No worries.
Okay, sure. Let me just take a minute.
No worries. While we're waiting, we had some great chats from everyone who is currently in, just saying thank you so much for the incredible important perspectives that people are getting, and to reflect and engage on these as they're talking about global surgery research. Some things that that some of the people in the chat are talking about based on what we've already talked about is the idea of health equity, professionally supporting each other and each other's needs. Things that many medical students should consider and are really looking for equitable work when we're talking about global surgery, which is great. We do have some people from Incision, which is our global partner in global surgery. So we have students from all around the world, not just the States, who are here with us. And some of them are chiming in as well, just saying thank you again for the great and interesting lecture and being understanding and trying to support, again, that health equity, both when we're talking about health, but also about professions and supporting each other, which is great. So again, we thank you so much for your remarks. That's fantastic. While we're waiting for Dr. Dyer to do those slides, do you think that you would mind just talking quickly about how you would advise the students here in, we're targeting specifically with US students, but how you feel like they can best get involved with global surgery research?
Was that directed at me or Dr. Dyer?
Yeah, if you wouldn't mind, just while Dr. Dyer is working with Anusha on the slides.
So I'm kind of done. I sent a Dropbox invitation to Anusha. I'm not sure what'll happen now.
Perfect.
I
Okay.
am downloading them. It should be a minute.
Oh, good. Oh, good.
Biggest suggestion to students who are interested to engage, you know, my experience of working with students, and I've worked with all types of students, medical school students, master's and PhD students at schools of public health. You know, the nice thing is they do have a good amount of time if you look at their availability across their whole training program. So a medical school student in any given moment may not be able to give more than 2 to 5 hours a week, but if you look at that over multiple years, then it can really be something substantial. And so for those of you who are interested in projects, I think identifying a faculty early on that you might want to attach to and develop projects with. And again, recognizing if in your first and second year you only have 10 hours a month to give, they're probably not going to put you as a lead on something, but will keep you exposed. But by your third or fourth year, can give you more responsibility and more roles that might be aligning with what you're interested in. For me, the challenge is when a student shows up and they're like, I have 2 months to give right now. Give me a project right now. And there's no history with that person and then no guarantee after the 2 months. So I think the earlier you can engage with someone, the better.
That's fantastic. No, I totally agree. If you wouldn't mind, another question that came in that I think is related to that is, so making yourself available is what you're saying, and not just like in the short term. But they wanted to know kind of this, you're talking about the health equity and getting others involved. What about how can you best get colleagues from low and middle income countries involved in conducting research there in their own country, or maybe even in other countries that are surrounding?
Dr. Dyer has some thoughts on that as well. And so I am 100% ready to answer that question, but let me just check. Are those slides ready yet?
I think
We have about 20
plan.
more seconds. It's a pretty large file, so you definitely have time to answer the question.
You know, again, I generally think of that more as the responsibility of the coordinating faculty. My experience is that the better projects are the ones that faculty are leading and students are leading in real and meaningful ways and contributing to intellectually, but that the faculty research can be done on the timeline that a student might have. And so, you know, my role as a faculty is to find things that I can put into smaller chunks that I can hand over to students, and that I make sure that when I hand something over to them, that I've identified colleagues on the ground that can absorb and support them, and that those colleagues on the ground are also getting their professional needs met and whatever that means for them. And so it's honestly, you know, that was a bit to my first point of, you know, one of the best things you can do that is to find faculty that you think are doing that well and attach to them, because that's going to give you the best opportunity. And then I think as much as you can, if you've been, you know, ways this has worked well for me in the past is for a student to come to me and say, I really want to have this more meaningful match. And so then I will take extra care to find a good fit, which is not a trivial task, but to find someone who has expertise and skills that are complementary to whatever. To really take that relationship seriously, to make sure that they're both learning from the colleague that they're matched to, but that they're supporting the colleague's professional as well. And again, I try to nurture that because I don't know that students necessarily know what they have to offer to maximize or what they could benefit the most from that relationship. But I think as much as you can keep that in the forefront of your mind of, okay, I'm committed to this person, and so how can we mutually benefit? There's a thing about Harvard School of Public Health that does this in a very concrete way. It's called the global cohort, where they actually identify matches in the first year of their training program, and then they jointly develop projects under faculty mentorship over their entire schooling. And so that might be something for students to consider, especially through Incision, where there's medical school students both in the US and in various parts of the world that are looking to grow their careers.
Hello?
Awesome. Thank you so much. I am ready with the slides, Dr. Dyer, so I can share my screen, and then as you want me to go forward, I can do so.
Okay, that sounds fine. So I will, first of all, thank you very much for having me. It's an honor to be part of this. Listening to Dr. Gautheir, it's interesting how parallel my thoughts are, and yet complementary. So I hope this is a useful combination, having the two of us. So you asked me to say a little bit, if you can flip ahead maybe through the disclosures and acknowledgement, and then onto the first couple of pictures, like the one of the woman sitting in the rubble. This, you asked me to say just a little bit about who I am and how I became involved in this work. So I am a surgeon. I'm a practicing orthopedic surgeon. I work in Boston, and that's how I got into this. I began really all at once with a single event of now 10 years ago, being called to be among the first surgeons who went to provide help after Haiti's earthquake in January of 2010. That, if I can skip two more slides ahead, was the culmination actually of my plan. This was my second career. Before this, I served as an active duty Air Force officer. I did intelligence work, and while on active duty, got interested in whether spy satellites could help medical response after natural disasters, and went to medical school really thinking, although I didn't know much about it, that I would become some kind of a trauma surgeon or emergency surgeon. I didn't even really know what that meant, but I imagined myself kind of zooming to disasters and sweeping in and helping in the short term. That was really my mindset. And so I went to medical school and then trained in orthopedic surgery because I liked it, and also because I thought it would be a good place for somebody interested in emergency work. And then almost 20 years later, when I finally got to go to a disaster, what I found was plenty of opportunity to do that kind of work, but also something much more. So I'm flipping ahead in my slides myself. I'm now up to a slide of a colleague with a lamp on her head looking at the camera. So it was just quite a shocking experience. Not so much that there was a disaster, of course I knew that, but just how much need there was for surgical education. That although a lot of what we were able to do was because we were uninvolved in the disaster, didn't have our own family under rubble, a lot of it really was because of better and more consistent education in orthopedic surgery. And so I came back from this disaster thinking much less about short-term kind of emergency response mindset, and much more about what it would be like in the long term to dedicate myself to improving surgical education as it began in one country, Haiti. And now for 10 years, I've worked pretty consistently along those lines. I think that it's a pretty powerful surgery is really a powerful development tool. If you think about the economic value of keeping a person of laboring age able to care for their family, the multiplier effect of a single surgical or non-surgical intervention by a surgeon is really tremendous. And so the economic value and the human suffering value of surgical teaching, I think, is really tremendous. Along with that really goes the importance of understanding both the best ways to teach and whether teaching as we're doing it is working as we want it to. And so really that's become now a big part of what I do. So I've gone from thinking I would zoom in and do surgery to thinking I would zoom in and teach surgery to realizing that my best potential for long-term help is in patient kind of slow relationships and in figuring out what works and what doesn't over the long term as an educational partnership. Thinking over the years I've been doing this now, I've visited the country of Haiti a lot of times, and over those years have forged real friendships and long-term collegial relationships with individuals and institutions in Haiti that do great work and are very interested in the same things I am. Also along the way, and this is why it gives me particular pleasure to talk to this group, I've realized just what a great resource medical students and other trainees are in doing this work with me, really on both sides of the partnership. So although on this call, I think we mostly have, or substantially have, American medical students, among the most important partners I've had and colleagues I've had have been Haitian medical students who I've watched grow up, so to speak, go through their own training and become full-fledged colleagues in Haiti, which has been a great pleasure. And it's also been really enlightening over the years, and I'm now flipping a lot of slides ahead. I have a list of publications that have come from the work that I've done. So none of this is at the level of Dr. Gautheir's NIH-funded research. This is really these are small projects funded by small grants and addressing small and immediate questions, but I think with larger impacts. So trying to figure out such simple things as, if you go to a place like Haiti and hold a medical conference, and what's the best way to figure out the topics for the conference? The obvious answer is you ask the people you're partnering with, and so to make a rigorous point of that, we tried to study how we put together the agenda each year, and have found really innovative things. For example, one year we brought an audience response system. As far as I know, maybe the first time that a high-tech audience response system has been used in a place like Haiti, and found that it was kind of a perfect way to allow people without the embarrassment of raising their hand to say that there was something they didn't understand or had questions about, give them the perfect way anonymously to say what their real knowledge gaps were. And so by capturing those anonymously, electronically, and continuously, we were able to really analyze that, and each year we've been able to build on that kind of technology to deliver a conference which would be educational. Other projects that have come out of that conference collaboration, some of them have followed the particular academic or professional interests of the students involved. For example, we had one kind of series of side projects on the teaching of arthroscopy, and that in a really nice way met the needs and interests both of the Haitian students and trainees and also of the American ones. We had a group of American students interested, or residents, who were going into sports arthroscopy as an orthopedic career, and there's a burning interest in arthroscopy and modern techniques in sports medicine in Haiti as well. And so we were able to link those interests together and just show that the teaching of basic arthroscopic skills works very well in a place even that is basically not seen arthroscopy in a widespread way. That's been a rewarding project. Similarly, another trainee who was going into pediatric orthopedics focused his work actually for a couple of years on the training of Asian practitioners in the use of different kinds of cast and surgical techniques for management of pediatric conditions, and showed successful knowledge transfer and good retention of everything that was learned. I guess to summarize and make a point out of that, I think this illustrates how, as a student approaching the field of global surgery, if that's what you're interested in, you can really use it in order to explore some other aspect of your intended career trajectory at the same time. And so just be on the lookout for ways to combine what you are already interested in and what you see coming next for yourself, because there's quite a lot of overlap and synergy that's possible. I'll finish up just by saying a couple things about the in general philosophy about research in a low income place. One of the questions that came to me before this, in order to prepare my remarks, were what's a way to ethically or appropriately do work like this. Although my work is not interventional in the sense that there's any kind of experimentation, on people in other countries, I think anytime rich people come on airplanes to countries that are more poor with some agenda of their own, you should always take two or three breaths, really think carefully about whose needs you're really meeting the most. And so we've tried very much to guide all of our teaching and all of our research by the stated interests and priorities of our partners in Haiti, and to always to keep their interests in a primary way. Then it's much easier to stay in a good place as far as research ethics. And I guess I'll stop there because I know we only have a few minutes left, and I want to be sure that participants have a chance to ask questions.
Thank you so much to both of you. This has been fantastic. So many great things have been mentioned and different opportunities. So thank you so much. A couple of questions that we'd just like to hear from both of you on, if you wouldn't mind, is what you kind of look for in your own mentors when you were looking for mentors, and maybe a little bit about them. And then on the other side of that is, what do you look for in a student who's approaching yourself for mentorship to do research? As was mentioned earlier, you know, making sure you're available and not just giving, maybe I'm only available for these 2 months, what can I do in this short period of time or something. But maybe you could just talk about again how you found your own mentors, what you looked for, and then now when as faculty members, and how you look for students to mentor as well.
Dr. Gautheir, you want to go first since I was just talking?
Sure. So, I mean, just one comment is I'm always looking for mentors. You know, at any given stage in your career, you should have folks that you're looking to for mentorship. And I think it should be across a variety of domains. So when I work with medical school students who have an interest in global surgery, I typically co-mentor with someone. So that's just a comment. Co-mentor with someone with more of a clinical background, because I may be able to teach you statistical methods and help you think about equitable research, but I can't lay out for you career trajectories in surgery. And so just know you shouldn't be necessarily only seeking out one mentor, that there's a variety of ways that you can identify mentors. So again, I oftentimes will approach it as, here is 10 years from now, I would like to have this aspect of my life better developed. And who are people who have careers that live that value that I'm trying to develop, or exercise that skill that I hope to exercise. And then I try to align myself to them. Again, when I was in the earlier stages of training, it was oftentimes in the very much, how can I help you? How can you put me to use to better support your work? And then as I gained more skills, the ways I was being used became more concrete. But I'm sure, you know, I saw in the comments there was a question of like, well, what if there's no global surgery program here? I'm sure you're surrounded by really dedicated faculty that you could align yourself to and learn a lot from, both clinically and in research. What I look for in a student, one is flexibility and you know, a willingness to work on a variety of different types of things depending on where my project is currently sitting. I do try to find out what their interests are and try to find the intersection of what their interests are and what my current needs are, but it might be a little bit fuzzy on both sides. And so the more flexible, the better. I look for folks, you know, if all things being equal, I had someone who had 5 hours a week for 2 years versus 5 hours a week for 4 months, I'd go for the one who has a longer extended period. I don't, at least from the statistical content, you know, I look for someone who's demonstrated to me that they're good thinkers, but I don't look for statisticians because that's my job, is to train people to do statistics. I do look for people whose values align with mine, and that usually terms up either in conversation or CVs. I can tell that they've got the right mindset to be a good fit for me. But these are relationships, and not every, you know, probably half of you on this call wouldn't find me to be a good fit for you for whatever your career goals are. So I think exploring different types of mentors before you lock into something is also good from the mentor and the mentee side.
No, I think those are wonderful comments, and I wouldn't say anything different. I guess I would only amplify a little bit and say that I think that every one of these relationships is two ways, for the students on the call, you should realize actually how much we get out of a relationship with you. It's actually like a big part and the joyful part of why I do what I do is for those relationships. I think that every that every project of any kind should satisfy three goals. Number one is it should produce something. So you should not get into sort of a boggy dead end thing that will not ever be done. And so finding somebody who has a track record of actually finishing projects and sort of knows how to get stuff off the desk and into print is important. That's a very simple thing, but that is important. And there are dead end projects and dead end advisors, and you can sort of figure out who they are. But that's the first thing. Number two is I think in every project you should learn something you didn't already know, whether that's about a field of study, about a surgical technique, about a country, or maybe it's a research methodology. Maybe Dr. Gautheir will teach you some statistics, something. You should learn something new. And then number three, and this is really the most important part, is that every good project really is the beginning or sustains a long-term mentoring relationship that really transcends the projects and lasts for a lifetime, ideally. And that's you should approach every project hoping that that's what you're going to get out of it. They don't always, but that should be your objective, not just a paper, not just a summer, but a lifelong advocate and mentor.
Thank you. Both of those are fantastic. And maybe I could just add one more follow-up question to that is, how do you feel like students can be best, as Dr. Dyer, you had mentioned that it's kind of a two-way interaction. How can students best give back to the faculty as they're, getting mentorship, whether it's from Dr. Gautheir about statistics or something? How can they give back to you guys as faculty? Where are they best useful, I guess?
Well, I think I'll say something corny but true, which is by succeeding. I think it's the dream of every teacher to be exceeded by a student, and so just being excellent is very important, and very rewarding to me. That is when the people I've advised do great things. That's my greatest joy. To put a more kind of practical how-to to that. I think Dr. Gautheir said it really clearly. It's helpful if you are just honest with yourself and with me about what your timeline is, what your capacity is, what your true level of interest is, so that we can find a project that doesn't either demand too much or too little of you, that you can do well at, that will be satisfying to you, that will sustain you even when it's sort of boring or slow or not going well. And so I think honesty and clarity and insight, sort of self-awareness, is probably the first step. And then I think just energy and passion is next. I don't think anybody's on a webinar at 9 o'clock on a Sunday night who's not pretty interested in this. So I'm assuming that everyone listening to my voice has a real deep interest in this. But figuring out how much time and interest you really have and what your timeline is just very helpful up front.
Yeah, I don't have much to add to that. The reciprocal, I think, is equally true of, if you found the faculty that Dr. Dyer is recommending, that you find folks that have demonstrated success in their own work, but then also in supporting students, that person would almost certainly also be very specific in what their needs are, right? So, I learned the hard way, and I think most faculty do learn the hard way, of letting students drive, the specific projects that they're going to work on and the specific timelines by which those were going to be achieved. It wasn't that they were never successful, but the pathways to success were often much more winding and less clear. And so now you know, a student comes and says, here are my general skills, my general interests, my timeline, and I'm able to come back and say, this is specifically what I need to achieve in the last year that I think you would be a really good match for. And I try to offer it as, you know, here's 3 different projects that I can put before you that have different types of roles. Which do you think would be the best match? But, you know, to your question, Taylor, whoever proposed the question, you know, how a student can be best supportive to faculties and their needs, to listen to that and to really take, you know, if I'm clear in what my expectations are, to take that seriously, and to really help, again, for mutual success, help fulfill that role, and not to keep shifting what that role will look like.
Great, thank you so much. Just a reminder, if you do have any other questions, feel free to put them in, because we'll have just like
questions. So feel free to send those to me.
questions.
The next one that
So feel free to send those to me.
about is
The next one that,
what type of, so for
students who are in high income countries who would like to participate in global surgery research, but maybe they don't are at an institution
where that's not supported.
Can you hear me?
Yes.
Yeah, that's
Sorry,
better. You were very echoey for a minute there. That's better now.
My apologies. Can you hear me? So if they're at a high income country, what can they do if they are, it's not supported by faculty or something at their school? How can they best get involved with global surgery research? So this is for just like a small plug for GSSA. We do have a big database that is able to connect people at various institutions interested in global surgery and try to get them involved, which has been great. But maybe do you guys have some other suggestions that they can do in addition to this?
No, I was going to flip that right back to you, Taylor, actually, and actually give you a pat on the back. No, I think that I think this is, I mean, I think what you've done is remarkable. You should be really proud of it. I think you've created a pretty good pathway. I don't know if we can call it a clearinghouse quite yet, but a pretty good pathway for people who are places that really don't have a lot of local resources, to connect them to other places that have more. I think this is the best way to do it. A network of students.
And I would say, you know, a bit similar to my earlier point of, and Dr. Dyer can speak much more to this, but having been around surgical trainees, fellows, residents, students for a couple years now, the path for a career in global surgery is not always obvious. And so I do think if you as a student envisioning global surgery, utilizing this network to identify a surgical mentor would probably be important and specific, because if you're trying to do it within your school, they may not know what those paths are, and it may not feel like an encouraging avenue to pursue. So finding the Dr. Dyers who can mentor you in that would be incredible. From a research perspective, again, linking back to my talk, I think there's a lot of ways to be really creatively engaged in global surgery research, even beyond quote unquote global surgery projects. Some of our most interesting work right now is in water, sanitation, and hygiene. So is there someone in your school community that's doing water, sanitation, and hygiene work that you could go to them and say, you know, you're looking at A, B, and C, here's the study in Rwanda, could we try and replicate that within your context? You know, when we write our grants, we don't write them as global surgery grants. Nobody funds global surgery research. We write them as maternal and child health grants because they're C-section research. And so I think if you can take that same mindset, if you're looking for research projects, and just look at the broader health system's global surgery questions and identify researchers within your community that have something that could be pivoted to be a global surgery project, would be a fantastic opportunity. And honestly, those are the projects that probably down the road would more likely get funded anyway.
Thank you. I think you bring up a huge component of it that I would like to end with. Our last question is that of funding. So I think that's an awesome idea to try and maybe think of it a different way. If it's not going to get funded through the global surgery way, then you can kind of frame it differently to meet another goal that might be more fundable. So what the question is what avenues currently exist when funding is kind of your limiting factor? What kind of ways can students still make an impact, but with limited research funding?
I'll jump in. So, and again, the first studies that I highlighted, the operational research studies, all of those were done with essentially no budget because the data already existed in charts. And if you read any of the papers, yes, we acknowledge the limitations that there may be missing data, but you can still see the signal through the noise in those studies in terms of health systems opportunities and health system gaps. If you're working with faculty, you know, ideally they've got the overarching cost that you could, you know, if they're covering larger costs, then you can typically do things for relatively low costs within that. So when we're about to launch a new prospective study, we'll reach out to our broader community of experts and say, if I already have a woman as a captive audience, what would you want to know about? And so we typically add in 3 or 4 additional questions that are just sitting on a shelf for someone to come along and say, I need a project. So ideally those things are lower cost. And then I think where we're looking for better creative funding is through societies that I think there's just an increasing interest in funding folks like you to be engaged in this work. And so you know, there's a surgical infection society, which as a non-clinician, it's like crazy to me to think that there's a society just on infections from surgery, but they have tons of fellowships. And I think looking at these very specific societies as ways to get some seed funding for travel or for smaller research projects and then embedding them within larger projects would help do some high quality work on a low budget.
Yeah, I guess I would just agree with that and amplify it, that there are that this research can be really cheap, that the most expensive thing can be traveling if you need to travel, and even that is maybe a few $100s, and that there's a fair amount of really small grants, kind of $1,000 or $2, often available from medical schools for all sorts of research that you can, or sort of student support, from some, at least in orthopedic surgery, my field, some specialty groups within orthopedics. So, for example, among the different projects I mentioned, there was a small funding from the Arthroscopy Association of North America for the arthroscopy project. There was a some small funding from the Pediatric Orthopedic Society of North America for a pediatrics group, pediatrics project. And each of those was, of just a couple $1,000s, but it's enough to get it off the ground.
Thank you. I think these are really great ideas. And I'd also like to put out one more in there just from orthopedics, since I've worked with you, Dr. Dyer. Another one that I've explored a little bit more now that I'm in business school is partnerships with industry, right? So Stryker and some of these other orthopedic groups will fund research as well to, help with their corporate sustainability and trying to give back, but also, to get their name out there as well. So those are great options as well for students if they want to, partner with industry as well. So unfortunately, I think we could go all night about this. This has been absolutely incredible. We really, really appreciate both Dr. Dyer and Dr. Gautheir for coming and sharing both surgical points of view, epidemiology points of view, and really giving us a really well-rounded background on how to get involved with global surgery research to the leaders in our field. And we really thank you for mentoring our students and helping us all out. And if there's anything else that you guys would like to add before we finish.
No, only again to say thank you.
For me as well, it's great to engage with this group and look forward to interacting with you more in the future.
Thank you so much. You're getting some great comments from different people just saying it was very invaluable. Thank you so much for being with us. We do have students from all over the world on this call, and this call will be posted also on our website. So other students will be able to listen to it later and be able to continue to learn from you both. So we really thank you for that. And just one more shameless plug about the global surgery database that has been created by GSSA and for all of you students who are interested in getting involved with global surgery research and maybe don't have some of those things at your school that you want to get involved in. We do have the database that is growing rapidly and has a lot of great resources on there of faculty and students who are looking to get involved with global surgery research and who either need students to come and help them, or are students who are looking for mentors. So we have that both. I see that Parissa, one of our co-chairs, has posted the link in the chat for all of you. So if you want to check that out, you can look at the database. And then the last thing resource that we have is that we as the research team created a complete toolkit, a research toolkit that you can check out online that we can also put in the chat link. But you can just go to the GSSA website and see it there as well. But this is a toolkit that I helped to write with the research team to help people to kind of start from developing a question, finding a mentor, finding funding, all the way through to publication and how you can get involved with conferences and things like that as well. So hopefully that is of help to you as well to check out. And there is actually a survey on there if you wouldn't mind when you use it to just click on the link to do a quick 2-minute survey so that we can better understand your needs as research people in GSSA. So thank you again, everyone, for making it tonight. Apologies for my I'm abroad right now as we talk about global surgery stuff, doing global surgery research. So we work with the limitations we have, so I apologize again for that. But thank you again so much, Dr. Gautheir and Dr. Dyer, for joining us, and we will end now.
Thank you very much.
Good night.
Days and good night.
Have a good night, guys.